Hello and welcome to Erwin Mitchell's Spinal Cord Injury webinar. My name is Chani Dhaliwal. I'm a partner in the London Serious Injury team. Many of you will recall the Spinal conference we hosted in our London office last year. Again, this webinar is a joint event between our London Serious Injury and Medical Negligence teams. The theme of the webinar this year is maintaining good mental health and well-being, and it follows World Mental Health Day, which took place on the 10th of October. This webinar will offer an insight from key professionals, as well as those affected by spinal cord injury, of how to maintain good mental health despite the challenges faced with a spinal cord injury. I'm delighted to introduce the panel of speakers today. You will first hear from Dr. Ramanuj, who is a consultant psychiatrist and clinical lead at the London Spinal Cord Injury Centre at the Royal National Orthopaedic Hospital in Stanmore. His session will be followed by Sophie Lester, who is a specialist case manager and spinal occupational therapist with Independent Living Solutions. Our third speaker is Ian Younghusband. Ian is a counselling and wellbeing officer at the Spinal Injuries Association. Ian was formerly a peer support officer for the North East, and he's also a registered member of the British Association for Counsellors and Psychotherapists. Our final speaker today is Anne Lutman Johnson. Anne is a former colleague of mine. She was the client liaison manager at Erwin Mitchell, and indeed I had the pleasure of working with Anne on my very first spinal case, which I worked on as a trainee many moons ago. Anne is now a mentor and trustee at Backup. The speakers will have 10 minutes or so each. We will then have a Q&A session, which will be hosted by my colleagues Anne Kavanagh and Rebecca Cherry, who are senior associates in our medical negligence team, and also my colleague Jessica Bowles, who specialises in serious injury. There is a Q&A function which you can use to send through your questions during the webinar, and there will also be an opportunity to ask questions at the end. And just by way of reminder, please do complete the feedback forms and return to us. Let's start the webinar, and I'd like to hand over to our first speaker, Dr. Ramanuj.
Thank you. Thank you for asking me to speak today. My short talk is going to be divided into three broad topics. First, I'll provide you with a brief overview of some of the emotional reactions that people with spinal cord injury go through from when they're injured to throughout their lives. I'll then hone in on the early psychological effects. I believe the speakers after me will talk about some of the medium to longer term effects. And then I'll touch briefly upon how and why we might want to distinguish normal psychological distress as a result of a spinal cord injury from a diagnosable mental illness. I focus the talk from the perspective of a clinician, but I hope much of what I say will make sense to the non-clinicians in the audience too. I'm going to turn off my camera so that I'm not a distraction. But next slide, please. Okay, so spinal cord, oops, I think we've moved a bit too far ahead. Previous slide. Yeah, thank you. So spinal cord injury is a life-changing event. Therefore, by definition, you should expect you or your patient's life to change. Similarly, adjusting to a spinal cord injury or disability is a lifelong process. When your patient is first injured, adjustment focuses on dealing with the loss and learning all about the injury. As they accept, learn and master new skills, they can incorporate these into their daily lives. This typically happens after discharge from acute inpatient rehabilitation and in the context of the real world. Okay, next slide, please. So your ultimate goal is to help your patient learn to care for themselves in a manner that is as independent as their disability allows. And so this isn't just about psychological well-being, this is about physical rehabilitation as well. So that your patient can begin the process of building a life that's not just focused around the disability. In the beginning, this may involve learning what it means to be a patient with spinal cord injury, dealing with ever-changing emotional reactions, doubting that they will become a productive person, questioning if life is worth living anymore, losing independence, learning to care for themselves in the context of all these physical changes, and then regaining independence. All of these are normal responses. Next slide. So after this initial adjustment period, your patients may need to incorporate skills they've learned into their daily lives, live day to day with a different level of independence, re-establish themselves in their families, at work and in their communities, change or adapt their activities such as work, parenting and leisure, and develop new interests. Next slide, please. Ultimately, your patients want to be able to live a meaningful life with their disability, a life that gives them a sense of purpose and accomplishment. And that's what we're aiming for. As they regain independence and integrate themselves back into their community, they can move beyond their disability and assume other aspects of living a meaningful and purposeful life. Okay, next slide, please. So I will focus on the immediate aspects of the injury. What happens in the first 6 to 12 months? I often get asked, is this person coping? But what does that actually mean? I like to think of coping as involving two interrelated functions. When some big change affects our lives, all of us have two tasks. The first is to sort out the practical. If a marriage ends, then who keeps the dogs? Who takes the kids to school? And so on. In spinal cord injury, how do I mobilize? How do I sort out my bowel and bladder issues? How do I earn money? The second task is dealing with the great waves of emotion that wash over us. The sadness, the guilt, the frustration, the shame, the blame. Coping means dealing with both these tasks equally. We can get lost in one of these tasks and neglect the other. We can get so caught up in our emotions that we stop engaging with our physiotherapy. Or, on the other hand, we can get so focused on regaining our mobility again that we don't listen to the voice inside us that says, it's all right to feel sad now. Okay, next slide, please. Alongside coping tasks, and quite early on, your patient will need to adjust to different life roles. Changing roles may mean relationships with family and friends need to be different. They may be seen as just a patient and not as a contributing member of their social network. They will need to reclaim their role and carve out a new role for themselves. They may be more dependent, physically, emotionally, financially on someone, and they may lose some formal responsibilities and gain new ones. For example, they may no longer be able to mow the lawn, but they can fold the clothes. Next slide, please. Now, all of the things I have described are normal experiences. Yes, even questioning if life is worth living anymore is a normal reaction to a spinal cord injury. And all people with spinal cord injury will go through some version of this. For most, that is where it ends. But for some people, the emotional reaction can become pathological. How do we know if a reaction is physiological or pathological? There's only one test, really. If the emotional reaction limits or prevents the person taking part in therapy and moving on with their life, then it is an issue. The other side of the coin, of course, is that some people, or many people, may have had emotional and behavioural problems prior to their injury, and these may worsen after a spinal cord injury. We know that about 1 in 6 people in the UK will have a diagnosable mental disorder at some point in their lives, and 1 in 4 will have significant psychological distress. So it is very likely that people with spinal cord injury will have also had mental illnesses in the past. Finally, we know that sometimes accidents and traumatic injuries can happen as a result of a mental illness. The accidents and traumatic injuries are far more common in people with serious mental illnesses than the general population. So people with serious mental illnesses such as schizophrenia and bipolar disorder are far more likely to need spinal cord injury rehab than the general population. Okay, can we follow? Next slide, please. So People with SCI who develop a mental health condition have a substantially increased risk of significantly lowered quality of life. A psychiatric diagnosis can be made in about 40% of people with a recent onset SCI. The most common psychiatric diagnoses are substance abuse disorders, adjustment disorders, and depressive disorders. Post-traumatic stress reactions are common in people following a major stressful event, like a car crash or an assault. And if not appropriately treated, these symptoms can go on to develop into a post-traumatic stress disorder. Okay, next slide, please. There are a number of factors that predict vulnerability to psychiatric illness. These include a history of psychiatric disorder, including substance abuse, a family history of a psychiatric disorder, a history of impulsiveness, which is overrepresented in SCI populations, a history of family fragmentation, lack and especially recent loss of an intimate relationship. Now, of all those factors, one thing stands out: the level and the severity of the spinal cord injury and the extent of related injuries are only weakly correlated with psychiatric illness, or not at all. It doesn't matter whether the person has a tetraplegia or a paraplegia as to whether they will develop a mental illness. However, the presence of chronic pain, such as neuropathic pain, and chronic fatigue are consistently associated with depression. Just as importantly, there are a number of factors that protect against vulnerability to psychiatric illness. These include helpful social support, a robust perception of self-management and self-control, what I call self-efficacy, an ability to problem solve, social access and integration, and employment. Next slide. On spinal cord injury units, people are frequently said to be depressed, but this is not always the case. We know that non-psychiatric staff, non-mental health trained staff, tend to overestimate psychological disturbance with a consistent bias to overestimate depression relative to what the patient says they feel. Why might this be? Well, the reaction to spinal cord injury is very similar to grieving. Both grief and depression present with physical complaints, a preoccupation with a former self-image, feelings of guilt, feelings of anger or irritability, and behavioral changes, for example, avoiding social activities. The differences are that, unlike depression, grief dissipates over time as the individual learns to live with his or her injury and impairment. The most important distinction between grief and depression is that people who are experiencing a grief reaction will focus on loss, such as the paralysis and the accompanying secondary emotional reactions. For example, the individual with a spinal cord injury might regret the high dependence that comes with it and the consequent change in their quality of life. In depression, on the other hand, the focus is self-critical. It presents with feelings of worthlessness, hopelessness, helplessness, and withdrawal from others. Major depressive disorder is not a normal, necessary, or essential part of the process of adjusting to a spinal cord injury, but brings with it huge distress. Findings suggest that those who are least depressed function best during rehab and later after discharge. The reason I make this point is that it is not always easy to know whether someone is having a normal reaction to a spinal cord injury or something that needs treating, which is why specialist care is important. Next slide, please. But there is another more important point. Beyond the impact on quality of life, mental illness is associated with a reduction in quantity of life. This is a study from Australia that shows that as life expectancy of the general population, which is the red line, has steadily improved over the past 30 years, that of people with mental illness, and this is all mental illness from depression to schizophrenia, has stagnated, or in some cases fallen, so that the gap in life expectancy is somewhere between 10 and 20 years for people with mental illness compared to the general population now. Next slide. And the cause of this premature mortality is not suicides or accidents, as many people might think. People with mental illness die of the same things that will kill many of us: heart attacks, cancers, pneumonias, strokes. It's just that they happen 10 to 20 years earlier in people with mental illness. Next slide. So the implication of these findings is that it is crucial that people with spinal cord injury receive psychosocial treatments because they've been shown to be effective in reducing psychological morbidity and improving quality of life. These treatments should focus on the development of adaptive coping skills that are designed to improve mood, enhance a feeling of control, increase capability for social engagement, improve self-management, improve employability, increase understanding of the influence of their injury on crucial areas such as sexuality, physical and mental health. I think that's my last slide, actually. Till I come back on. Okay, next slide. Yes, it is. Okay, thank you very much. Shall I hand over to, is it Sophie who's following on from me?
Yeah. Good morning, everyone. I'm going to spend some time just following on from that presentation, talking to you about some of the experiences I've had as a case manager, working with people who have got a spinal cord injury, who have come through a spinal unit and are back out in the community, or perhaps they've had a gap, such as something like our lockdown that we've just had, and the experiences of helping people thinking about their mental well-being. This is a little bit of a whistle-stop tour this morning, and a lot of the areas that I will be covering are things that I could talk about for a long time. So this is a whistle-stop tour this morning for you. Next slide, please. So some factors to consider that are really key when working with someone out in the community. The first one really is about being really helping someone understand their expectations. So by this, I mean realistic versus unrealistic expectations. And these dovetail into all of the elements that I'm going to be talking to you about this morning. Firstly, expectations for someone of actually what do they want to be getting back to? Elements of, are they big expectations? If they're big expectations, are they realistic? And if you have really high expectations on yourself, sometimes when we don't achieve those expectations, it evokes that feeling of failure, which actually has quite a significant impact on your mental well-being. The other expectation to think about is that expectation of, as you're leaving that really comfortable hospital environment, about what that community provision might be like when you're back out of hospital. So is it discussed around actually what are those expectations of community provision around therapy, around nursing support, around care support? And those are really key discussions to be having with someone to help balance that level of expectation for them. Also break the expectations down, so make them really bite-sized chunks to help someone balance what those expectations might be. The next factor is a really key one for me, and this is about routine and structure. So as human beings, we are incredibly habitual beings. We crave meaning, we crave occupation, and as human beings, we crave having a purpose. And in a way, routine and structure helps us do that. And it's important to us because it gives us that ability to plan. It gives us that purpose and occupation as human beings. It also links back into expectations, because again, when you've had a spinal cord injury, it is about being realistic about perhaps what those routines and structures might look like initially when you first go home and leave hospital. It's also about I would really encourage thinking around what is important to you when it comes to routine and structure. Is it that very first part where actually what's important to you is to be able to be getting out of bed, getting yourself dressed and just being up, and for example with your family? Or is your expectation around your routine slightly bigger, but really try and tease out what is important for you with a routine and with a structure. Next slide, please. So activity levels is another really important factor for me when I'm thinking about someone with mental well-being being out in the community. We know that having good activity levels, your body produces lots of lovely endorphins, hormones, which impact on all kinds of different things, one of which is serotonin, which actually has a direct link on your mood. And actually just 10 minutes of activity can boost your serotonin levels to give you an increase in mood. with that serotonin level increase, it helps things like regulation of your sleep, which I'll talk a little bit more about in a minute. It can help your mood, it can help your appetite, and so it starts to dovetail around all of these different elements. When we talk about physical activity, I'm not talking about going out and doing a 3K run 5 times a week. I'm talking about a level of activity that just challenges, works your muscles, works your body more, that requires more energy than if you were resting. So that can be a really high level of activity, or it can be something like yoga or something quite low level in terms of physicality, but actually it is activity. And also the other aspect to activity is actually getting out, being out in the fresh air. We know sunlight, for example, also helps with serotonin levels. So actually that physical process of being outside, out of your house, can also help with your activity levels and help to boost that mood. This activity levels dovetail into routine as well. So again, start small, something that's a really small activity that you start to build into a routine, and that helps again with that routine and that structure for you. So I've touched a little bit on sleep and sleep habits. Now, when I talk about sleep habits, I mean the things we might do habitually around sleep. So for example, do you go to bed and watch TV? Or do you go to bed and use an iPad, use your mobile phone? And if you're doing that habitually without really thinking about it, that's a sleep habit. And so we all know, we've all probably been there where we've had a couple of nights of really poor sleep. We're really grumpy the next day. We don't really want to do very much. And actually impacts our activity levels and our ability to really function on our normal day. If you're having multiple nights of really poor quality sleep, so perhaps you're not going to sleep until 3 a.m. in the morning, or you are perhaps not sleeping, so you get up and maybe do a bit of physical rehab at 4 o'clock in the morning, those are then going to impact on your next day. It's going to really impact your mood, your appetite, your routine, and predominantly you're going to probably crash at about 4 o'clock in the afternoon. Have a sleep, which then impacts on your next day. So sleep and sleep habits are really cyclic in nature. And the links to mood, routine and structure are quite phenomenal with poor sleep. And actually, you quite often don't realise it's happening until it really is quite an issue for you. So sleep and sleep habits has a massive effect on routine, structure and your possibly low mood, but also just poor mental well-being. Next slide, please. So your diet and appetite are also quite key for me. Apart from anything else, eating 3 times a day is a routine for you, but also it's about what you're eating and that level of nutrition and hydration for you. Because actually, if you're eating well, you feel good, which naturally increases your mood. But if you're well hydrated and you're eating the right things, you do have that ability to really think about routine and sleep, how they're dovetailed together, and how you feel like going out and doing some activity when you're eating well and you're looking after yourself. Leisure and hobbies is another area that I think for some people gets pushed aside sometimes. And I think the leisure and hobbies are about doing something that you really enjoy. And that isn't rehab focused necessarily. And they are part of who you are as an individual. So the balance is really key. The balance between rehabilitation activities versus resting, which is really important, as well as that balance of things that are part of you and not rehab and not going to an appointment 3 times a week. It may well be that you perhaps need to look at what's important to you and what things you do want to get back to, but thinking about developing that balance across your week and across your routine is absolutely key to help with your mental well-being. So you have lots of lovely variety of different activities, and your productivity is really key as well. So it does link into hobbies and balance, but also it's the productivity of what's important to you, physically getting yourself up and washed and dressed, and perhaps your goal is to take the kids on the school run. That is really productive. It's working you in terms of rehab, but it's not physical rehab, and it's that productivity for you across the day, which again links back through into routine, it links into structure, it links into activity levels, and it's they're all interlinked. Next slide, please. So your environment, I feel, is also quite key to your mental well-being. And this can be an environment, if we think about the environment that you've perhaps come from in terms of a spinal unit or a hospital environment, very set up, very accessible for you, moving into perhaps that home environment or a different environment or a work environment that actually isn't necessarily completely accessible or set up, and it can make things very challenging. And so again, it links back through into those expectations around actually looking at what can you expect going into those environments, problem solving it, thinking about how can that be made easier, or actually that part's not important to me, so I'm not going to worry about that. I'm going to focus on the areas that are. I also feel there's the sense of fear and unknown is quite big in terms of mental well-being. So if you don't know something, or you don't know the answer to something, or you're particularly worried about an element, then actually this can increase anxiety, which then can have an impact on sleep, because actually your mind can't switch off, which in turn impacts your routine and your appetite. And I think sometimes having those really talking about those, what you're fearful of and what you don't know, can be really beneficial, because your brain does tend to fill in the gaps when you have a lot of unknown questions in your own mind. And it's really easy to fall out of routine and structure. It takes 12 weeks to make any change into a habit. It's very quick to break down the other way. And so installing, for example, routine and structure relatively early on can be quite key. And again, it doesn't need to be, again, break it down into smaller chunks, so it doesn't feel such a huge expectation or a huge step, but actually small chunks, build it up, but have some discussion around what does that routine and structure look like before you get to that place where you realise you've fallen out of a routine and a structure and the impacts it's having on your mental well-being. Next slide, please. So I think the take-home points for me are about being kind to yourself and being realistic with yourself. Setting yourself huge expectations can have a negative impact on your mental well-being. So start small and build it up, but also have those discussions, perhaps before you come into the community or very early on when you're at home. Have those discussions about what's important to you, what do you want it to look like, because they can help set those goals of perhaps where you need some support for help working on it, or perhaps actually then it's really clear to the people around you what help you do need. And for me, nutrition and hydration is key, really. If you're eating well, if you're eating well and drinking well, then actually your body's well looked after, and you are giving yourself a really big kickstart to help with these different elements that are actually very dovetailed together and very key for helping mental well-being. I think for me, those are the main points. I think I'm now handing over to Ian for you, but if you do have any questions, please do ask, as it is a whistle-stop tour through the different factors to consider.
Hello. Hello, everyone. Thanks, Sophie. Just to follow on from Sophie's talk, I'm going to just say a little bit about some of the longer term effects of. Hello, yeah. Sorry, I don't know if I was live there before. I was maybe speaking a little too early. So thanks a lot. Yeah, just to follow on from Sophie's talk, and I'm going to just say a few words on some of the longer term issues that affect people and affect their mental health, and also some of the support that the Spinal Injuries Association, SIA, can offer people. So to kind of reiterate what Sophie had spoke about earlier, that lack of structure and purpose, I think that's particularly over the long term one of the major things that people struggle with. And so people who've maybe been unable to go back to their former employment, and sort of they've maybe lost their role within the family. And initially, quite often I find with people who I've worked with in the past, they don't really have a reason to get out of bed, and lie in and sleep in till late, and that often snowballs with some people, and they maybe don't get out of bed for a couple of days at a time, and so having that structure and trying to maintain that in your day and having a real purpose is really important. So to try and look for maybe some alternative meaningful things to engage in is massively important for people in their mental health. I think one of the other things that really impact people is that lack of bladder and bowel function. And if you speak to most spinal injured people, they would say that they would rather have that function back than to be able to walk again, believe it or not. And that often can have a massive effect to the point where people won't engage in going out anymore. They're fearful for having accidents and the embarrassment. And so that can be a major factor in people in how they engage, and particularly those who haven't gone through a specialist rehab setting. So maybe they haven't had access to that specialist knowledge around bladder and bowel management. So in that case, they maybe don't know of the solutions that are available to be able to help with that. So would maybe urge that they maybe contact our nurse specialists in a situation like that, and maybe find a solution that enables them to live their lives a little better. I think one of the other issues affecting people a lot is if they're having to rely on the district nurse service. Now, spinal injured people come a little lower down the priority of patients, unfortunately, and so that can result in the timing of calls being fairly sporadic, and often people aren't able to get up into their wheelchairs and start their day until around 1 o'clock in a lot of cases, which that doesn't really leave a lot of time to be able to engage in anything meaningful, or maybe go out anywhere or very far for the day. And so maybe trying to see if there's different ways of managing, say if that's the bowel care, or maybe seeing if there's alternatives with maybe care solutions, with maybe care agencies that could provide that, maybe a solution to help with that. But that is something else that can have a real impact on people's mental health. The length of time people have to wait for equipment, that's something that can be really difficult, and particularly, as Sophie had mentioned, having to maybe live initially in housing that's not suitable or adapted, and particularly if you're going through the disabled facilities grant process, that can take quite a long time, or if you're waiting for social housing. Speaking from my own experience, I had to live for 2 years in my parents' dining room and go to an old people's home for a shower once a week as a 22-year-old, which as you can imagine, the effect on mental health can be pretty damaging. And so often, if people, with the amount of things you've got to deal with, can be quite overwhelming. So it's quite often, it's a good thing to kind of maybe get people to maybe focus on one thing at a time and try to deal with one thing, and then try and problem solve various things. And sometimes looking at things too far ahead can maybe seem overwhelming too. Maybe trying to kind of live more day to day can be can help people initially, whilst these things get put into place, and gradually life gets a little better that way. So I think one of the other major things is dealing with the uncertainty around care and care funding, if you having to rely on care, and that adjustment as well within the family. If you've got people, carers coming in and out of the house, and the different dynamics within relationships, particularly people who are in relationship and married, finding that balance, if you need care, between carer and husband or wife still. That's one of the things that often takes people time to adjust to. So I just like to quickly move on to some of the support SIA can offer to people. So we've recently restructured how we offer our services to more of a network approach. So we offer information, advocacy and support through our support network line. So people can contact that, where we now have a closer relationship with some of our trusted partners, both regionally and nationally, which includes the major spinal injury charities such as Backup and Aspire. So we're still continuing to offer regional peer support through our support network officers and a team of volunteers. So as in the past, we've offered support in spinal injury centres, neuro rehab units, district general hospitals, through to people's homes. Now that support's continued through the pandemic, which is obviously now virtual, but will continue again once things have settled down and gone back to normal, if they ever do. On top of that, so I mean, that's practical advice, emotional support. We've got a peer-led counselling service, which I lead. So we offer to a maximum of 10 sessions, but on average 3 to 6 sessions, depending on what people's needs are. Advocacy, particularly for people who are struggling maybe with care funding, both socially and through continuing healthcare. And we have a specialist nurse service, which obviously gives a lot of specialist advice, particularly around bowel care, that sort of thing, to healthcare professionals and spinal cord injured people. And that's offered as well through our academy. So people, if they're checked online on our website, spinal.co.uk, then there's a lot of information on the different training services that we offer through our academy as well. So that's a bit of a whistle-stop tour. So I'd like to hand over to Anne now.
Thank you very much, Ian. I hope people can hear me. My name is Anne Lutzman-Johnson, and I was going to talk to you, first of all, a little bit about my personal experience. I became spinal cord injured, gosh, 36 years ago now, I think it was. And I've always considered myself to be quite a strong, resilient person. I was fairly focused on where I was going in my life, but my spinal cord injury completely, destroyed my confidence, I think. At the time, I was a student at university, living in my own accommodation. By the time I came out of hospital, my university had finished, and so I ended up going home to my parents, like Ian was saying in his talk. So there I was, aged 22 by then, and back home with my parents in what was not a wonderfully accessible house, although I was able to get upstairs. We had a stair lift put in, and at the beginning, I think, well, I don't really remember an awful lot about when I first came out of hospital, but like Ian says, I didn't used to get up in the morning. And when my sister said to me, why don't you get up in the morning? Apparently I replied, what is there to get up for? And that was, I think, the way I felt. I was lucky because I had something happening to me in the future. I had a place at law school for the September. I came out of hospital in December, so it was 9 months after I came out of hospital. And in that 9 months, gradually, I set myself little goals. I got a lightweight wheelchair, then I got a car, then I moved out of my parents' house into my own flat, and then finally I started at law school. And I think it was those little goals that really helped me get my life back together. There was very little psychological support given in those days. There weren't psychologists in all the spinal injury centres. Backup didn't exist at the time of my injury. SIA didn't have its peer support scheme. So, yes, I pretty much made do on my own. And I would have really liked to have had some sort of help and support at that time. What has happened now is that, well, 15 years ago, Backup, which is a charity that I became involved in, mainly because I wanted to learn how to ski, and they were running courses, including skiing courses at that time. So I went on a skiing course, and then I met a whole load of other people with spinal cord injury and discovered that actually, you know, that there were other people out there who were in my position and we could learn from each other. And 15 years ago, Backup set up a mentoring scheme. This was set up by two clinical psychologists, one of whom is spinal cord injured herself, and the other is married to somebody who's spinal cord injured. So they have a pretty broad view and experience of a spinal cord injury. And the mentoring scheme, I became a mentor with Backup, and probably about 12, 13 years ago. And I think in that period, I have mentored probably that sort of number of people. The idea of mentoring, this is not trained psychologists. What it is instead is people who have lived experience, and Backup have about 100 spinal cord injured mentors on the scheme. They try and match people up as best as possible in terms of personal situation, your age or age at injury, your professional career, your aspirations, your personal situations, such as whether you've got children, whether you're a mother or not. I mean, I don't have any children, and most of the people I've been mentoring are in a similar situation. So we can relate to each other. As well as having spinal cord injured mentors, Backup also have about 50 family trained mentors who can talk to spouses, parents, children, brothers, sisters, because everybody suffers when someone has a spinal cord injury. It's not just the injured person. So the fantastic thing about the mentor training is that, you know, we go through a weekend-long training session, but it's continually reinforced with additional training for those who mentor. And they also have clinical supervision from these psychologists. So this is not a replacement for psychological support, and sometimes can go alongside people who need to have that more in-depth psychological support to help them. But the good thing about mentoring is that you are speaking to somebody who's been there, who's lived the experience, who's done it. And I think that's what's so valuable about this service. So really, I mean, I think it is recognised that psychological support following a spinal cord injury is an essential part of the rehab process. having tailored support from someone who has direct and similar experiences is fantastic, and someone who also has their own support available. It really can help people adjust to what is a life-changing experience, but doesn't have to be a negative experience. I think, you know, I would like to think that since my injury, I've gone on and lived a very full life. I'm still living a very full life, despite what's going on at the moment. Obviously, this pandemic has put a bit of a stop to various social activities. But I think the important thing to say to people is that you can get your life back. It will be a different life, but it can still be a very good life. Go out there and seek the help that you need from the organisations, from SIA, from Backup, from the other charities, and from your friends. I think one of the most valuable things I found was actually talking to my friends and admitting that, yes, I was depressed and I needed a bit of help. And yeah, and that did help. Anyway, I think I'm now passing over to Anne to ask any questions or anything. So thank you very much.
Hello, sorry, I think I was on mute there for a couple of minutes. It's Anne speaking, and myself and Jessica Bowles are going to put some questions to the panel. The first one, I go back to Anne, I think. Aside, Anne, from the peer support and obviously family, if injured, spinal cord injured people are fortunate to have family members available, but aside from that, are there any digital supports that you could recommend, like mindfulness or meditation apps, or is there any other digital mechanism that people can use to bridge those gaps?
If that was directed at me, I am not the most digitally competent person out there. Yes, I think both SIA and Backup have online forums and chat rooms that you can go into if that is your preferred method of seeking support. And certainly during this pandemic, Backup developed a lot more online support for people because clearly we were all shut away in our homes, and that was one of a good way to get support. I think also the mentoring service received a lot more requests for assistance, and so the mentoring that Backup does tends to be telephone calls rather than, it's not face-to-face and it's not online. So and I think, well, I've always been one that I prefer the one-to-one on the telephone rather than digital. So that's, but certainly there is a lot of stuff out there if you know where to find it on the internet.
Oh, okay. Could I just put that to Sophie, if you can hear me?
Yes, yeah, I can. So just to add into what Anne was saying, there are some apps available for specifically things like mindfulness that you can download via an app store on your mobile phone or iPad. One that springs to mind for me is Headspace. Another one is Calms, I think. But again, they're nice apps that take you through just some mindfulness daily exercises. Again, it's not everybody's preferred cup of tea, so to speak, but as a tool to help perhaps calm some of that, any anxiety or stress or worry. It is quite a nice habit to get into. So they're available via app stores on your mobile phone.
Okay, thank you. And this is a question for Dr. Ramanuj. Can you explain how pain contributes to a deterioration in mental health, and how are healthcare professionals working in partnership to provide a holistic approach to patients?
Yeah, sure. So, I mean, there are biological, psychological and social explanations as to understand how pain impacts upon mental health. We know, for example, that pain is associated with similar structures in the brain that feel emotional pain as well as physical pain. So if that's not reducing, then the brain, in very simplistic terms, can get overwhelmed and find it difficult to differentiate between, well, what's going on? Why am I still in pain? You know, pain is supposed to be an acute thing. It's supposed to happen, warn you of something happening, and then dissipate. When it goes on, the brain can kind of go, well, hang on a minute, why is this still going on? But beyond that, of course, there are psychological effects. If you're in pain, you're not likely to want to do things. And all the stuff that all the other speakers are talking about maintaining routines, about having activity, about having good sleep and so on, pain will have a big impact upon that. And therefore will have secondary effects upon your mental health. And conversely, we also know that if you're feeling anxious or low in yourself and you have a bit of pain, that pain can be amplified. So there's a bi-directional relationship. And so what you want to try and do is that you want to try and tackle both together. That often means that you need many professionals working with you in a multidisciplinary format. It's not just a psychologist talking to you about your pain and trying to help you live with it, and neither is it just a physiotherapist trying to help you to move despite the pain, etc. And often those two people, the psychologists and the physiotherapists and the case managers, also need to talk amongst themselves in order to help you get beyond that. But pain is a huge field, and we know that it has a direct impact on and indirect impacts on on how people feel about themselves.
Thank you. I will pass over to Jessica, I think now, who's got some further questions lined up, perhaps to address to other members of the panel.
Thanks, Anne. So I've been collating the questions as they've been coming in, and I know that Ian has replied directly on one of them, but I think it would be really helpful to actually have him respond, so it's part of the recording as well. So the question was about routine and structure and the fact that it's very important, but commonly spinal cord injured clients have the challenges of acquiring pressure sores, which means that they have to be in bed rest for long periods of time, which isn't normal and obviously disrupts their routine and being able to go out and do things. So is there anything that you'd recommend in respect of being able to work through that to keep up their emotional well-being during those difficult times?
I think as I kind of replied directly, it's very difficult being on bed rest with a pressure sore. It's one thing being in bed ill and feeling ill, but when you're in bed with a sore, you feel well and you feel you should be out and busy doing things, so that impacts even greater, I think. But I mean, again, trying to maintain as much structure as you can while in bed, which the temptation's there to end up sleeping through the day, that sort of thing. So to try and avoid that, still getting starting your routine at a reasonable time or the same time as much as possible, and then trying not to doze or sleep through the day. That I think something as well, and just trying to engage with people as much as possible, say using social media, that sort of thing, email. But yeah, it's very difficult. I think particularly with precious sores, it's the nature of them, they're so slow in healing them, that you can start to become despondent very quickly, as there doesn't seem to be any light at the end of the tunnel. So I mean, again, just trying to sort of take each day as it comes. I mean, and some people, they may be able to learn some things while on bed rest. I don't know. There's obviously a lot of online educational things you can do now, or maybe some upper body exercise, that sort of thing.
Perfect, thank you so much. This is more of a general question, and I don't know whether or not, I know we normally nominate people, but if someone wants to answer from the whole panel, that would be helpful. Someone's come with a question about the cultural issues surrounding disability and the stigma that people live with in certain communities, which have profound impact on our clients' well-beings or patients' well-beings. Can anyone offer any advice to those patients or in those circumstances?
Shall I give you my 2 cents, I guess? I would say that there are 2 main ways to tackle this. So cultural context is important for all types of problems, both medical and otherwise. Obviously, there's a particular context when it comes to people living with disabilities, and there can be great stigma attached to it. So what I like to think of in trying to tackle it is 2 things. One's empowerment and the other's education. So empowerment of the person who has the disability to be able to educate others, I guess, and to be able to advocate for themselves against the negative effects of stigma and so on. But also I find that the cultural misunderstandings come from a place of ignorance, not so much that someone is particularly trying to be malicious. And so what we tend to do is involve the family and the carers in the rehabilitation, and often also in the psychological counselling that we do, and that often helps to get beyond a lot of the problems. Can you still hear me? Yeah, okay, so I mean, that's what I was going to say. I don't know if anyone else has more to add to that.
Doesn't sound like it, but as you're there, Dr. Ramanoush, one other question that's come up for you is, as people are potentially already more psychologically vulnerable due to COVID, so family health, uncertainty around employment, etc., do you see different outcomes for the newly spinal cord injured patients? Or have you noticed a difference?
Yes and no, which is a typical psychiatrist answer, isn't it? But so I mean, all of us are having to deal with changes in our routines, in our lives, in this kind of sense of tension that sits, I feel it, a sense of tension that sits underneath what's going on. There are announcements being made on a weekly basis, including today. What's going to happen? Am I going to be able to see my family tomorrow, etc.? And so, of course, that will have an impact on people, and that can be doubly difficult to maintain routines, to maintain social contact, etc., when you're disabled, and so that can have an impact for sure. At the same time, and I've spoken about this before to people, I've also had a reaction which I wasn't expecting from a lot of my patients, which is you know, for the first time, people have understood what it means to be isolated, to not be able to go out as much as you want to not be as freely able to go down to the shops and pick up a pint of milk, to have to plan whether you go to the gym and how you do that, etc. And a sense that people feel more understood as a result from others, from society. They feel that people are maybe a bit more kinder. So there are both, you know, there are both effects. There are the increase in anxiety and so on that all of us having to contend with and poses particular challenges to people who have a disability, and yet at the same time a sense of maybe being better understood and more empathetic reactions. So yes and no.
Thank you. And then I know there are a couple of questions for Sophie when she was talking about the balance between rehab and doing activities that kind of resonate with who you are. One of the questions was, do you ever recommend a rehab holiday so people can focus on or work out on what's important to them and focus on family rather than just getting caught up with their rehab?
So really good. That's a really good question. And I think it comes down to helping that individual understand and really giving them that opportunity to discuss it. I think I've never recommended a rehabilitation holiday, although COVID, the lockdown that we've recently had with COVID, did provide that opportunity due to limited access to community-based therapy. But I think it comes down to what comes right back to that individual's expectations and understanding of the impacts it's having on them, but also what are their expectations, and trying to kind of almost peel that onion back, if you like, about what is why underneath, why is that focus there on having lots and lots and lots of rehab appointments? Does it come back to their belief about, if I have physio 5 days a week, I'm going to be able to walk normally? And that trying to peel that back with them. I think it's also really good practice really to be talking with someone and challenging someone in those discussions with those different elements of rehab and goals and balance about where their priorities are, what is important for you. And sometimes I think it's about just stopping and really trying to explore with that person what is really important to them, because that in itself feeds some of that discussion for them. Don't know if that's completely answered the question for the person who asked that question, but I think it does come down to the individual that you're working with and that understanding and those expectations.
Thank you, Sophie. That's really helpful. Thank you, Sophie. That's really helpful. That brings us to the end of today's webinar. Thank you for joining us, and thank you to our panel of speakers for their very insightful presentations. Some themes discussed include the importance of psychosocial input and adaptive coping skills, setting realistic expectations and goals, and the importance of routine and structure. It was also interesting to hear about the support and resources available. If you have any further questions, please do get in touch. Our contact details should appear on the screen shortly. And an electronic resource pack and a recording of the webinar will be available following the webinar. You can find details of future webinars on our website, and please do take time to complete the feedback survey because it's really helpful to receive your comments. Thank you and keep safe.